Welcome everyone to Bugs and Biofilm, Why Patients Bleed and Converting Bloody Prophies. Before we dive in, I want to quickly share some important disclosures. Our course is proudly supported by Boots, Bugs, and Biofilm, and I, Tasha, am a co-owner of Boots, Bugs, and Biofilm. And I also have my own company, Teaching Oral Systemic Health, where I specialize in advanced hygiene training, including microscopy. Jennifer Sider is the co-owner of Boots, Bugs, and Biofilm, and she is also the owner of MicroBlink DX, where she focuses on salivary diagnostics to help clinicians identify pathogens. So we both have financial interest in Boots, Bugs, and Biofilm, and of course our companies. We are super passionate about what we get to do, and this session is our opportunity to share our expertise with you. But we just want to be really transparent about our overall business relationships. As Dr. Rowling mentioned, our course agenda tonight, we have 1 hour continuing education for you with 1 free CE, so be sure to take your quiz. And then we'll have a 30-minute session after the presentation where you can learn more about what Jennifer and I do in our spare time, and then also for fun as well. And so without further ado, let's get into tonight's learning objectives. So we're going to talk about differentiating the difference between clean and healthy mouths, really understanding the primary causes of periodontal disease, talking about pathogenic biofilm, calculus, bacteria, all the good stuff, developing verbal skills and scripts to help you guys to convert those long-time patients that have wonderfully healthy mouths, but they bleed all the time. And then we're going to talk about some different personality traits that we all have. We all have individual personalities, but if we can streamline the way that we communicate with our patients, it doesn't really matter what our personality type is, we can really help our patients to understand that they truly do have an infection. Just a quick note, the content in today's presentation, including all of the slides, is property of Boots, Bugs, and Biofilm. We're happy to share slides with you upon request, but we kindly ask that you refrain from taking or using any of our material without our permission. We appreciate your understanding and respect for our hard work. All right, let's get into it. So every day, dozens of patients walk through our doors, flashing their beautiful smiles. And on the surface, they might seem healthy. But how do we really know if we're seeing the full picture? Take a closer look at these gums. They might seem healthy to the naked eye, but could there be something lurking beneath the surface? The question we should be asking ourselves is not, are our patients healthy? But how do we know for sure that they're healthy? All of us have been taught to use traditional diagnostic parameters for periodontal therapy. And this, of course, includes our 1 to 3 millimeter pockets is normal, healthy gums don't bleed, patients should have minimal plaque and calculus, overall, just not a lot of debris on their teeth. And of course, they shouldn't have bone loss. And if they meet that criteria, then they should be, in fact, a prophy, right? But if you guys are anything like me and you get into the real world, you may have patients that look more like this. They may have some localized lower anterior inflammation, maybe some localized bleeding on probing, potentially minimal plaque or calculus, no radiographic bone loss, and overall excellent home care. And we think prophy, right? They fit those qualifications. And then we get in there and it's like, yee, where is all this blood coming from? If you're anything like me, you're kind of left scratching your head because the patient didn't have a lot of stuff on their teeth. I mean, sure, I could work on more brushing and flossing, but they're already coming in regularly. There's not major disease, right? So it wasn't very clear what I should do. Maybe this patient is sitting in doctor's chair. Maybe they had their teeth cleaned 6 months ago, 6 weeks ago, or maybe even 6 hours ago. Why are their gums bleeding like this? Why is there just so much bleeding with just the slightest manipulation of the gum tissue? Is bleeding normal? But maybe this patient did go through some type of gum tissue therapy. Maybe they even did scaling and root planing. But after 3 months, 6 months, 9 months period maintenance visits, they're still bleeding. It's confusing when we know we've done all of the things that we were taught to do. So, does everybody bleed? I started to think so. But this is one thing that for sure I didn't learn in school. I didn't learn in school that the amount of bleeding would determine the amount of infection. But somehow in my mind, it did become a thing. So does it really matter how much bleeding is present? So many times I would see a patient that had some bleeding, wasn't anything crazy, but they also had a little bit of calculus. And so I thought, just get the calculus out, like a splinter stuck in your finger. That inflammation and bleeding should resolve, right? But then other times it wasn't a little bit of bleeding. There wasn't any bone loss. Maybe it was the same patient. Last time I got the calculus out, but this time they're still bleeding. Why is it not working? I definitely knew when I saw a bloodbath, that completely wasn't normal. But when a bloodbath happened in a patient's mouth that didn't have a lot of debris, that's where things got a little bit confusing. So, another thing that I definitely didn't learn in school is how easy it was going to be to become super normalized to bleeding. In my mind, this is what periodontal disease looked like. Kind of some dirty mouths, patients that had clear red rolled margins, quite a bit of debris on their teeth. They didn't do a good enough job at home. They needed my help for sure. But most of my patients typically presented more like this. Their gums didn't look amazing, but they certainly didn't look terrible. The woman on the left-hand side here, I mean, up close in a photo, her tissue just looks irritated. It's easy to think, well, maybe she's just brushing too hard. Maybe she's using a new toothpaste that's too abrasive. Maybe she's a mouth breather. Maybe anything. What about the woman on the upper right? Why are her gums so receded? Huge black triangles. She's somewhat red. Is it just all those years of bruxism and not wearing a night guard? Yeah, she needs grafting. But will the grafts even hold with that amount of bruxism? Or is there something else lurking below the surface? What about the woman on the lower right? If you look closely at the color of her gums, the texture, the overall appearance, the maxillary and mandibular look completely different. Is it the bridges? Do her gum tissues not like the pontics on 7 and 10? What exactly is going on here? One thing that all of these patients have in common is they all bled a lot, but none of them had a lot of debris on their teeth. So many times when I thought about using my traditional diagnostic parameters, what I didn't realize is that my traditional diagnostic parameters were designed to look for the reaction to disease, not the disease itself. So in order to pass our clinical boards, these are the traditional diagnostic parameters we're looking for. We're looking at the overall periodontal pocket depths. Is this patient in the red or are they in the black? Do they have bleeding on probing? How many sites do they have? Do they have radiographic bone loss or radiographic calculus? And to get these patients healthy, all I had to do was to decrease the pocket depths, decrease the bleeding points, and decrease the amount of calculus. And bam, they should be better, right? But how do we know that they're better? How do we know that they're healthy? Most of us have been subscribed to the nonspecific plaque hypothesis that is unfortunately now pretty outdated. This hypothesis suggests that periodontal disease is the result of the overall quantity of plaque and overall debris on a patient's teeth. And so this has been widely accepted until more advanced technologies where we could actually identify certain bacteria in our patients' mouths. But when we think about the nonspecific plaque hypothesis, it really looks like this. We think any amount of plaque and calculus has the ability to cause disease. So the natural conclusion is going to be to remove as much plaque and calculus as possible. That should prevent the disease. But I ask you, does this gentleman's mouth look healthy? What if I were to spray some air on those papillae? Are they going to flap wide open? Probably. Isn't healthy gum tissue supposed to be really nice and tight, not red, light pink? But so many of us are so used to seeing bleeding every single day that these types of patients kind of can deceive us. Unless a patient has a mouth full of calculus and a ton of inflammation, they sometimes just, periodontal disease seems to fly below the radar. There's limitations to bleeding on probing, plaque, and calculus. And what we're really seeing is a different story when we really think about what these things are showing us. So a pocket can be both a symptom and an artifact, but it's our job to determine which one it is. It's our body's way of communicating with us. So with so many unhealthy patients, it's super easy to be desensitized. And so we really need to pay attention to these critical signs. 1 to 3 millimeter pockets are where all infections originate. These shallow pockets are where the infection is going to start regardless of bleeding on probing. So bleeding on probing, we know can be present with infection, but not always. So every single patient, because their infection starts subclinically, they're not necessarily going to have bleeding on probing, but those are often your patients that will have bleeding on scaling, or patients that just are not quite healthy, but they're not unhealthy. They fall into that gray area between the codes, if you will. But what we want to think about when we think about bleeding on probing or bleeding on scaling is that that is a sign of overall inflammation. And whether it's a little bit of bleeding or a lot of bleeding, it points to an infection. And I know the word infection can be a little bit of a sting to some of us. But one thing that we know about periodontal disease is that it's both a disease and an infection. But periodontal disease isn't always active. We could have a patient with a completely arrested infection. So they may have 5 and 6 millimeter pockets with bone loss, no bleeding on probing, no bleeding on scaling, and no active infection. The tricky part is if we're only using our traditional diagnostic parameters, how do we know if it's an active infection or not? But what we do know is that chronic inflammation causes the gums to become leaky. You can think of this as leaky gut. Leaky gut, leaky gums, very similar. When we see bleeding, that indicates inflammation. And when there's swollen gum tissues and we see bleeding, that means the gums are already leaky and permeable, which allows harmful bacteria to pass through the bloodstream, potentially leading to systemic health issues. So while bleeding on probing can be useful in the diagnosis and monitoring of active periodontal disease, when it's used as a standalone, it can be inaccurate and can be kind of late to the game. What about calculus? Some believe that the rough surface of calculus harms gums, but the rough surface alone doesn't cause gingivitis or periodontal disease. The main issue with calculus is that it holds onto plaque, making it harder to clean. So calculus isn't the direct cause of gum disease, so simply removing it won't stop periodontitis. That bears repeating. Calculus isn't the direct cause of gum disease, so simply removing it isn't going to stop the periodontal disease. Periodontitis does not require calculus. So many of us have felt for years that in order to do code 4341 or 4342, our SRP codes, that we must have calculus to scale off. After all, it's scaling and root planing. But what we don't all know is that those codes are inclusive of removal of bacteria and toxins. You do not have to have radiographic calculus. You do have to have bone loss, radiographic bone loss, because after all, it's scaling and root planing. But calculus doesn't have to be part of the equation. So how do we know? Back to how do we know if an infection is gone? To stop the inflammatory process, we have to stop the overall inflammation. So if we want to stop bone loss, we have to stop inflammation. After all, it's the body's inflammatory response that is destroying the bone and allowing bacteria to enter the bloodstream. So we need to examine the biofilm or perform a lab test to determine if bacteria is in fact hijacking the immune system. Bone loss tells us about the patient's past, but doesn't always reflect their current condition, and it's not necessarily predictive of the future. As we've all seen, patients can have a 5 millimeter pocket for 5 years that bleeds, but that doesn't mean that that pocket's going to end up to be a 6 or a 7 millimeter pocket. But if there's chronic inflammation, that means there's still bacteria going into their bloodstream, pumping through their heart, their lungs, their liver, the entire body. So it's not about the amount of bone loss that a patient's getting, it's about that chronic inflammation. That's how periodontal disease goes systemic. So we really need to understand the root cause of periodontal disease. Probe depths, bone loss, plaque, and calculus are not the cause of periodontal disease. They're symptoms of a much deeper issue. The true driver of periodontal disease is the bacterial imbalance and the body's immune response to it. So when harmful bacteria overpower the good, the immune system kicks into overdrive, leading to chronic inflammation and tissue destruction. We're constantly exposed to bad bacteria all over in our lives, not just periodontal pathogens, but all different kinds of bacteria. Most of the time, it's not a problem because that's what our immune system for. It keeps everything in checks. It's an overall checks and balance. But when the balance shifts in favor of those bad pathogenic bacteria, that's when the problem starts. So what creates these shifts. So where does the imbalance start? There's a huge laundry list, and this is only a very short list of what are some of those areas. So biofilm buildup. So plaque forms on the teeth and gums, creating a sticky layer of bacteria that overall matures. It doesn't want to go anywhere, so it produces that matrix material around itself. Well, when biofilm or bacteria hang out on the gums too long, that's going to elicit an immune response. The immune system is going to react to the biofilm and trigger inflammation. What about our patients with diabetes? High blood sugar impairs immune response and decreases inflammation, making it easier for harmful bacteria to thrive. Autoimmune disorders, there's over 80 now. This condition weakens the body's defense against infections, accelerating periodontal disease. Hormonal changes, pregnancy, menopause, and other hormone fluctuations increase inflammation and susceptibility to gum disease. Our smoking reduces the amount of oxygen in the gum tissue and weakens the immune system, creating a perfect environment for bacteria to flourish. Poor nutrition, deficiencies in vitamins, minerals, specifically vitamin C, these can all weaken the gum tissue and the immune system. Chronic stress, increased cortisol levels, then they suppress the immune system and contribute to inflammation. Certain medications, steroids, anticonvulsants, the immunosuppressant drugs for those autoimmune diseases, they can also affect the mouth's overall balance, leading to an increase in infection and overall risk. So if you think about this list being a very short, very concentrated list, think about how many of our patients are at risk. A pretty high number, right? And we know that oral pathogens cause systemic problems because they don't stay in the mouth. When you see inflammation and bleeding indicates to you that the pathogens are already going systemic. They don't just stay in the mouth. We have 60,000 miles of blood vessels in our mouth, so the bacteria can easily enter the bloodstream through swollen gingiva. The bugs are in the biofilm. The blood is our clue. It doesn't matter how much bleeding a patient has. Obviously, more bleeding may indicate more inflammation, or it may just indicate a larger immune response from that patient. It's not necessarily the indicator of how bad it is. So anytime we see bleeding, it's a red flag. So now that we have a clear understanding of what's really happening with bleeding gums, let's explore what we can do starting as early as tomorrow. So let's say your favorite patient, Jim, comes in. Jim's been a long-time patient, sees you typically every 6 months, but this time Jim comes in and it's been 8 months. You look at his medical history, there hasn't been any changes. He has high cholesterol and he's still taking a medication for it. But today you take his blood pressure and it's elevated. He wasn't aware of that, 130/85. He's not medicated, so you definitely want him to keep an eye on that. He says to you that he knows he's a couple months overdue and he has a confession. His electric toothbrush broke and he just started using a manual one instead of buying a new electric toothbrush. You complete your medical dental evaluation, you sit him back and you take a look at his gum tissue. And this is what he presents like. So, does Jim just need a good cleaning because he's 2 months overdue? Do you anticipate bleeding during scaling or probing based on his oral assessment? If you're to continue with the verbal scripts that I learned in school, you may say something like this before doing your probe chart with Jim. Jim, I'm going to check your gum tissue with this ruler. 1 to 3 millimeter pockets are normal, but healthy gums don't bleed. I'll let you know how you rate. You might be thinking to yourself, Jim, your gums are going to bleed, but I'm just going to let my probe chart do the diagnosing for me. You pull up the probe chart for Jim to look at with you, and you can show him, dude, you're in the red. You're not really in the black so much. Not such a great perio chart. Is it just because his electric toothbrush died? Maybe we should just give Jim a pass. After all, it's been 8 months, not 6 months. But remember, if we anticipate bleeding and we're already seeing bleeding on probing, that's already, his probe chart is already indications of periodontal disease. And if we continue with our traditional verbal scripts, we may say something like this to Jim. Jim, you have 12 5-millimeter pockets, 20 4-millimeter pockets, a lot of bleeding points, even some radiographic bone loss. And as Jim's trying to calculate all of these numbers and what they might mean, he may turn to you and go, "Oh, okay. Well, Tasha, I figured I needed a pretty good cleaning." And you may be thinking to yourself, no, sir. That is not what you need at all, is a good cleaning. But to Jim's defense, did any of the words I just used sound anything like infection? I talked about bleeding points. And if I were to say to Jennifer, "Jennifer, you have bleeding points," she may say, "Well, you poked me really hard, Tasha," versus bleeding. So it's one of those things, though those nuances are really important. Typically, what we do at this point is we start to go into our 10-minute spiel about periodontal disease. We start to teach Jim our language for periodontal disease so that hopefully then he can understand why he doesn't actually need a cleaning. So when we look at Jim's gum tissue and we see inflammation from the get-go, our mind's eye, what I want you guys to envision is this is very likely lurking below the surface, all that bacteria. And when you get in there, he's going to have bleeding. So he does have all the positive signs and symptoms of periodontal disease, often before we even do a perio chart. So when we talk about symptoms, they often don't sound like a real problem or like the infection that periodontal disease is. So I want you guys to be careful about the words that you use. Bleeding points don't sound as bad as bleeding. After all, if I talk about a point feels like a very localized thing. Inflammation and bleeding in the mouth is never localized to one spot, although it can present that way. Inflammation is a process that the body creates in its entirety, not just a specific spot between a couple of teeth. Inflammation versus infection. Infection can be such a hard word for us to say, but periodontal disease is both an infection and a disease. And if we're seeing active signs and symptoms of inflammation, redness, bleeding, bone loss on the x-rays, those are all positive signs and symptoms of an active periodontal infection. When we're talking about periodontal numbers, healthy versus not healthy, just simply talk about jawbone loss. If you see radiographic bone loss on somebody's x-rays, they've literally lost part of their jaw. If it was in any other place in their body, it would be very alarming. So instead of having our traditional conversation about pocket depths 1 to 3 millimeters as normal, healthy gums don't bleed, pivot that conversation to something that Jim would understand. "Okay, Jim, I'm going to evaluate your gum tissue health. As we now understand, the healthier your mouth is, the healthier your body is. If I see anything that could potentially cause you harm, I'll let you know." And then from there, you're going to see a change in Jim's gums, right? You already did an oral evaluation. You are anticipating it's not going to be healthy because you already looked. "Jim, I'm seeing a change in your gums today. You have redness, inflammation, and even bleeding. This definitely appears to be a gum infection caused by bacteria." At this point, as soon as you see I'm seeing a change, Jim's ears are probably going to perk up like, "What? She's never said that before. He's never said that before." And then he's listening to us. And so once we have Jim's attention, our next step is to say, "Jim, think of these bacteria like termites in the foundation of a house. They live deep inside your gum tissue, not just on top of them. So a good cleaning isn't going to take care of it." The impression we want to leave on Jim is that I found something different. Therefore, we need to do something different in order to get you healthy. So instead of having this conversation using my traditional words with the 1 to 3 millimeter pockets, Jim might have said something to me like, "Well, Tasha, it's been a couple extra months since the last cleaning and my electric toothbrush broke, so maybe that's why you're seeing a change." No, 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 no. We didn't talk anything about pocket depths, anything about bleeding points. We simply talked about health and lack thereof. So the response that we want to get from Jim is an infection. How did I get an infection? Because how many people think a cleaning is going to fix infection? Probably not too many. So if we want to go into the toothbrush and longer than normal cleaning schedule, we can simply say something like, "I suspect a couple extra months and your broken toothbrush to be factors, but ultimately you came in contact with some bad bugs and your mouth got sick." Think of the cleanings we've been doing like a routine car wash. It keeps things looking good on the surface. But what you need now is more of a full detailed cleaning. We need to get into the hard to reach spots using medicine to clean out areas that a regular cleaning just can't reach. This process, along with some simple home care on your end, is the next step to getting you on the right track. What we need to do is keep it so simple for Jim to say yes, but even more importantly, to understand. We do not want to over-explain. We don't want to teach him all of our dental terminology. We want to give him a definitive diagnosis with a very clear and concise path. Oftentimes, when we spout out into our 10-plus-minute conversations about periodontal disease, the patient is left a bit dazed and confused because they're not necessarily tracking with every step. So by the end of the conversation and they've turned into a bobblehead, they don't even remember what you said at the beginning because this is so brand new. So we have to keep it really short and sweet. The easier things is when we can really show patients more objective diagnostic parameters. There's no secret to why intraoral photography is so popular, why scanners now are all the rage. Why do we scan our patients? Why do we take all the time to scan our patients? Because we can show them so much more. We can show them the contours of their gum tissue. We can show them where they have recession, where they have wear. A picture is worth 1,000 words. So with photography, it's the same thing. We can show our patients not only the tissue contours, but we can show them the color. When a patient's mouth is unhealthy, it's not just unhealthy at the margins. They're not just blunted papillae. Their entire mouth and vestibule is red. The next step I love is the microscope, because when I saw a change in Jim's mouth, I could simply say, Jim, I'm seeing a change in your gum tissue today. I think you came in contact with some bad bugs and your mouth got sick. Let's take a plaque sample, put it under the microscope and see what's going on. It takes 30 seconds to take a microscope slide. I put it up on the microscope. 1 minute later, Jim goes, ugh, that's in my mouth? Yeah, this definitely explains the changes I was seeing in your gums. We know that certain shapes are not part of your good bacteria, but we don't know what they are without a lab test. Then we take the lab test. Wow, you have all but 3 of the bacteria that we test for. This definitely explains the infection. We take them through gum tissue therapy. How do we know our therapy was successful and how do we know they're healthy? Because we have objective diagnostics. We look at their gum tissue. Is there less redness, inflammation, bleeding? Yes, check that box. If we have a microscope, did we decrease volume, decrease motility, get rid of the bugs that should never be in our mouth, like a spirochete, for example? Yes, perfect. The next box, after therapy, do an after test, compare and contrast before and after. Did you decrease the overall number of bacteria? Yes, perfect. You're on the right track. I hope this part has been helpful. Next up, we're going to learn more about the specific bacteria linked to periodontal disease, and Jen is going to take it from there. She has a beautiful presentation for you. All right, Jen.
Hey, thanks, Tasha, for the tee up there. Loved it. So, back to infection. Can you see infection with the naked eye? We're diving right into the bugs. Let's do it. So, let's get calibrated. So, one thing that we like to do is we want to calibrate everybody. So, it doesn't matter if you are a dental hygienist like Tasha and I, dentist, dental assistant, office administrator, doesn't matter. We want to get everybody calibrated because everybody's going to be on the same page when it comes to treating this periodontal infection. Because what happens is, for example, Jim, Tasha gets him all lined up, talks to him about periodontal infection, all the things. He goes to the front and he says, now what are we doing? Or he calls and says, what are we going to do? So everybody's got in the office has got to be on the same page. So that's what I'm going to do. I'm going to calibrate everybody. So it doesn't matter if you've got an infection in your mouth, in your tonsils, in your lungs, on your toe, on your hand, coughing, wherever. Doesn't matter. What is an infection? It's too much of a bad bacteria. That's what an infection is. Doesn't matter where it's at. If it's on your toe, you've got an infection, it's too much of a bad bacteria. And that's what periodontal disease, it's an infection. So this, my friends, is periodontal infection. So this is what it looks like. So Tasha referred a lot to the microscope slide. And this is why we do like to implement a microscope slide is it takes that guessing. It's an intraoral camera for the gums. So as you can see here, we have a healthy slide, not a lot of action, kind of boring, kind of simple. And then we have an infection, bugs everywhere. So it takes that guessing game. So when you have a patient that, like Jim, and you're trying to convert over into something more than just a regular prophy patient, you can look under a microscope slide, and the patient's going to say, "Hey, is that my mouth? What do we have to do to get those out?" So it's a really good way to really look inside and get a quick snapshot of what's going on. What I really like about the microscope too is, you know how we always had to give a patient a course in, like a crash course in dental anatomy. We go in there, we probe, and we scratch around, and they're infected and they're bleeding and it hurts, and we're like, "Oh, you've got pockets and bleeding," and they're like, "No kidding, you are scratching around." So if we do a microscope slide, it kind of makes them own their own infection. Yeah, this is in your mouth. This is what's going on. So that is why we will see a lot of microscope slides in our presentation here tonight. So when it comes to the progression of periodontal disease, there's a great video on Dental IQ that I really like to use. But here's some still pictures on how the periodontal ligaments attach. And when you start getting periodontal disease, how they fade away, how they go away. And then you, of course, get into bone loss. And so what I like to say, my verbiage on periodontal infections are, you have an infection that's eating away at the bone in your skull. Yeah, take that for a few minutes. So, but seriously, that's what periodontal disease is. It's an infection eating away at the bone in your skull. No big deal. Okay, so just to get another little calibration here. So it doesn't matter if you use the word microbes, bacteria, pathogens, bugs, germs, doesn't matter. You say what you want. You're going to hear me say, Natasha said, all these words. It's all the same, but it's words that patients understand. They hear these words, they know what they are. They know. So we know there's 500 to 700 different types of bacteria in the mouth, and there's 11 that are linked to periodontal infections. And if you were to grow these pathogens and agar slabs, here's what you're looking at. I don't know, not something I want to put on my wall. So anyways, this is kind of a nice picture of them. So also, we're going to show some result reports of bacterial testing. This is Microblink DX. So as you can see here, I hope y'all can see my cursor. These are the 11 pathogens we're testing for down here. And then this is the antibiotic threshold line. So anytime there's bacteria above that threshold line, that means it's too much bacteria for the body to fight off with just mechanical debridement. We got to do something more. So think about this. You go to your physicians, they do your blood work, and you have to have some sort of a guideline. Is this normal or not? So this is our guideline. This threshold line is our guideline as of to, is this normal? So if they're above that line, no, it's not normal. It's too much bacteria. And then also, we are going to list in the result report an systemic antibiotic. Of course, we want to be very careful when administering antibiotics, but it's just a suggestion. So let's say you have a patient that you've tried everything on. You've done scaling and root planing. They've been in, you've done laser, you've done this, you've done that. Nothing's working. So that may be an opportunity to where you want to administer an antibiotic. So we tell you what antibiotic will kill the exact pathogen that's present. So that way it's not a shot in the dark, and you're not just recommending everyone say a broad spectrum antibiotic. We tell you it's a customized antibiotic according to the patient's bacteria load. So that way you can administer an antibiotic. And then also we, of course, give other treatment considerations. And then if you want to know the exact name of the bugs, your patient may, they will find these down here. So it all starts with biofilm. So you know how, and I say dental hygienist because that's what Tasha and I are, but you know how you brush your teeth in the morning, you go through the afternoon, you see your last patient, you go to lunch, and you rub your tongue across your teeth, and you feel that fuzzy little sweaters hanging on your teeth. That's biofilm. So biofilm builds up in about 4 to 5 hours, and then that's what everything attaches to. But what I like to tell a patient is this. This is my sweet Doberman Tessa. This is her dog bowl. is not now, of course. I did this for the video, but see how that biofilm layer, you know how you feed your dog over and over and over and you get that slime layer around the dog bowl? That is biofilm, very similar. It's just that sticky substance that everything else can attach to. We also call that the purple complex. We don't need to test for it. It's not really pathogenic, but it is that first layer. The ultrasonic works great for getting the biofilm layer off. And then also the microscope slide, if you do a culture on the microscope slide, you may see some critters running around with the biofilm layer. Hopefully nothing too crazy. But the next one is the green complex. And we do test for that because it is moderate and pathogenic. So we do want to test for it. You're not going to see a lot of action if you do a microscope slide, but you will see a little bit. It's that next layer up. Scaling and root planing usually does a good job with the green complex. It is resistant against metronidazole. So if you are going to recommend an antibiotic, you're going to want to do amoxicillin or Cipro and perioprotect trace. We love perioprotect trace. They work really, really well with that green complex. Next up, you got your orange associated. These pathogens, we're just climbing this ladder. These are the next layer of pathogens. They're low in pathogenic except for EN. You are going to see some action on a microscope slide. When it comes to therapy, scaling and root planing, of course, is great using the ultrasonic. If you are going to do a systemic antibiotic, clarithromycin, if they're by themselves. And then the perioprotect trays, of course, work well with that. And those are some of the intermediate bugs. Then we start getting up there into the bridging species, those orange complex. They're aerobic, meaning they live with oxygen, and they are strong to moderate. So why they call them the bridging species is they bridge that gap between not good, not bad, but they bridge that gap. And so they're binding sites for bacteria for the red complex because they are aerobic. So they hop down to the pocket and they use up all the oxygen, and the red complex says, coming in. So that's what happens with the orange complex. They are an intermediate bug, all except for Fusobacterium, which is this pathogen right here on the right. They are intermediate bugs. So when we do see these pathogens, we're like, we can handle these. We got a periprotect trays. We're going to scaling root planing. If they're in high concentration and say you got a pregnancy patient, you may want to bump or a preterm pregnancy patient, bump up to metronidazole would work best because that is what will kill the orange complex. So we do see orange complex, of course, quite often. But what happens then in those red complexes specifically is P. gingivalis is what you don't want to see. That is a pathogen right here. That is all the studies. We know there's about 56 diseases linked to periodontal infections, and the red complex is usually they usually appear in most of those studies, unfortunately. So if you are going to do bacterial testing, if you do see the red complex and you do want to administer an antibiotic, you'd want to do metronidazole. It does do very well with the red complex. And as you can see here, I hope you can see it on the slide, with the red complex, you're going to see spirochetes. So that initial slide I showed you, of course, there was a lot of red complex in that. You can see the spirochetes running, and you're going to see, the more you see on the microscope slide, the more bugs that are present that you're going to see on the result report. So with therapy, scaling and root planing, you want to do scaling and root planing. You may or may not want to do a systemic antibiotic, depending on where you are with this patient. Periprotect trays, and then also do follow-up testing. That's super important to make sure you get those levels down, because that red complex, you don't want to fool with that because it can be definitely get you into problems. So one of the big studies that appeared in 2019 was Alzheimer's. And so P. gingivalis, which is it's a toxin that's released, gingapans, which is a toxin released by P. gingivalis, was found in 96% of the brain tissues tested in Alzheimer's patients. So that being said, if you do have a patient that marks Alzheimer's or that mentions to you Alzheimer's during their appointment, test them. Make sure they don't have P. gingivalis. It's kind of severe here, folks. They're even looking at the brain tissue, the spinal fluid, the saliva of these patients, and they're finding P. gingivalis. So this nasty critter, I mean, from the brain, from the mouth to the brain, it's not that far. It's not that far. So think about that when you have those patients. Next up, AA. This little guy, he's kind of crazy. We only see him about 25, he or she, 25% of the time. And this is the one you may have seen on the previous slide that we have to see with a different type of microscope. So not a phase contrast microscope that you would see this. So you would not see this on a microscope slide. So you would have to do bacterial testing to know if you did have AA. But it's a facultative bug. So what that means, it lives with oxygen and without. And we do see this in aggressive forms of perio and juvenile periodontitis. A lot of times when we do see AA, we may see AA, nothing else. Sometimes we see all of them. So it definitely can be a sneaky little critter. Scaling root planing, if you are going to do a systemic antibiotic, definitely amoxicillin, Cipro, then metronidazole, doesn't touch it. And I would definitely do follow-up testing with AA particularly, because you definitely don't want AA running around. It is you don't see, like I said, you don't see it often, but we definitely do see it. So when it comes to the different types of bacteria, we need to know, like, okay, what are we concerned about? We need some sort of a guide. So here's our guide: our scaling and root planing resistant bugs. So these are our scaling and root planing resistant bugs. There's even studies out, and this is, studies from the 90s that show that AA and PG actually increase following scaling and root planing. And that's the reason being is because we're introducing oxygen down into the pocket. So they are shown to increase during that time. And then tissue invasive bugs, meaning they're in the tissue, the gum tissue. Because remember, your gum tissue is just skin. It's like skin on your forearm. So supposedly the amount of gum tissue in your mouth is what you have on your forearm. That's a lot of skin. It's a lot of gum tissue, like I said, is just skin, and that's a lot. So those are your tissue invasive bugs. So these are the ones that cause the redness. They're hiding down into the tissues. And then your intermediate bugs. What I like to say about the intermediate bugs is this. So think of it like grass fire pathogens. So let's say you have a grass fire and you're like, oh, we have a grass fire. You want to run out, stomp it down, throw some water on it, because at any given time the wind was to blow, something was to happen, and we have a major situation. So when you can test patients and they're in their intermediate bugs, you're like, okay, good. Got you, or, we can definitely treat this. We're good to go. So that's why it is good to do your diagnostics, your microscope, your testing. That way, how aggressively you need to treat the patient. Because remember, traditionally in dentistry, especially dental hygiene, I graduated in 1999, and we treated everybody the same, no matter how bad the infection was. So if you had a 5, you had a 10, scaling and root planing. We didn't do anything different with those patients. So now we know how bad this infection is, how bad this patient is, so we can customize the treatment like they do in medicine, because we are healthcare providers. So one of my favorite, I didn't want to get into too much oral systemic, but my favorite slide is this, or my favorite oral systemic slide, I should say, is this. If this was in blood transfusion, this is why I like this, because it's not in a dental journal. This is in a blood transfusion 2021, not that long ago. So blood donors with periodontitis are considerably more likely to donate blood contaminated with bacteria. Okay, so hear me out. So you donate blood. I go donate my O positive blood, and I've got an infection all over my arm. Because what they typically do is they look, hey, you got a tattoo. How healthy are you? They kind of do like the little nurse will do like a quick little screening on you to make sure you're good to go. But if you have an infection all over your arm, the nurse is going to be like, oh, that's strange. We don't, I think we're good. Why don't you come back another day? But if it's in your mouth, come on. So what they're finding is 48% of blood donors have periodontitis. That's not surprising. The study also, so I do encourage you to go and, locate this study, because this just blows me away. Because, I mean, think about that. Isn't surprising. 48% of blood donors do have periodontitis. I believe that. Y'all sit behind patients. You see that. So, yeah. So if you need blood, I'm here. O positive. Okay. So who needs treatment or converted to a perio patient? So we have these patients tomorrow. Who needs treatment? Who needs something more? Anybody with bleeding gum tissues, because we know that's the first sign of infection. If a patient has bleeding, if a patient has bleeding, that's the first sign of infection. Healthy gums don't bleed. Remember, your gum tissue is just skin. If you were to go to the bathroom, wash your hands, they don't bleed. There's no infection, but bleeding is the first sign. So you can always say, hey, I'm noticing a change in your gum tissues. Healthy gums don't bleed. We might have an infection here. And then also patients who are systemically high risk. And a lot of those patients that do have periodontal disease do have some systemic conditions going on. So heart disease, diabetes, anybody that's pregnancy patients, maybe somebody's going in for chemo. So those patients who are systemically high risk that check mark something on their medical history, like Jim, Tasha said he had high blood pressure. He's check marking some things. He's in his 50s. So he's going to be check marking some things, unfortunately. But those are the patients that we need to say, ding, ding, we've got a high risk here. We need to treat them a little bit more aggressively. Patients with implants are being treatment planned for implants. So they call, hey, I need an implant. Come on in. Yep, we need to do some further diagnostics. We may need to do bacterial testing, microscope. We need to really make sure that we don't place this implant into a bed of infection. It's important. Let's get a hold of this early on. So those are great candidates to do some more diagnostics on. Patients with 5 millimeter pockets. We know that. We know that anytime there's a pocket, that's a nook and cranny for bacteria to hide. So yes, anybody with pocketing, we need to do further treatment on. Patients who have completed treatment but still bleed after scaling and root planing, which is possible. So let's say you did scaling and root planing today on a patient. They come back in a couple weeks. You do a follow-up. They're still bleeding. Let's say they come back in 3 months. They're still bleeding. Let's do something more, because what we were doing is not working. Not that we're not doing a good job as dental hygienists, because we are. That's just what we do. We do good jobs as dental hygienists. I promise you. That's not what the conversation is. It's about how is this patient responding to the infection that we are treating. Because we are not working on patients a lot of times that are the stiller of health. So we have to keep that in consideration, that sometimes patients don't respond like any other thing in medicine. You didn't respond. We got to do something else. It is okay. Patients who need medical clearance for surgery. So those folks that say, oh, I'm getting hip and knee replacement. I need to get a clean bill of health from orthopedic. We're looking for decay. Great. But we also need to do something more. They're really looking to see if there is infection. Also, patients that are going to be going in for a major surgery, that are going to be intubated for 6-7 hours. They need to make sure that these bugs do not adhere to the ventilator tube and make their way to the lung. You definitely don't want them getting pneumonia after surgery, because it can happen. Okay, so how does testing change treatment recommendations? So one of the things is to determine how aggressive you need to treat the patient beyond scaling and replaning. Does this patient need an antibiotic? How infected are they? Do they need Perio-Protect trays? Probably so. If there's bleeding and pocketing, they need Perio-Protect trays. But also what the testing will do, it shows the patient, yeah, you have an infection and you've got to wear the trays. This is just not for glamour and looks. You've got to wear your trays if you want this infection to go away. Do they need laser? Do they need these different type of treatments? So it tells you how aggressively you need to treat it. Also, how frequent to set up recall appointments. Do you need this patient okay for 3 months, 6 months, 4 months? Where are we at here? Do more family members need to be tested? Because we know these pathogens go and are transmissible. So between family members. So if you've got a child, is the mother infected? Vice versa. Is the spouse? Who else needs to be tested? We need to treat periodontal infections like strep throat. Go home. Don't be running around eating, drinking after everybody. Shouldn't anyways. Get a new toothbrush. This is infection. Treat it like strep throat. Also, eliminate active infection prior to implant placement. Get rid of that infection. Don't place an implant into to embedded infection. Also, if you've got a patient that has implants that are maybe on the fence, starting to bleed, starting to get a little wonky on you, grab a bacterial test. Where are we at? How bad is this? Where are we going? Can we get this fixed quickly? And then also help eliminate the risk of surgical complications prior to them happening. So if you've got a patient that's going to be going in for surgery, clear them out before they go in. Okay, friends, key takeaways from Tasha and I. Don't just keep doing it because you're scared of telling patients the truth. We are healthcare providers as dental hygienists, and we know what we're doing. We're good. And these patients trust us. We've got to tell them the truth. We do not want them running around with an infection. That's what periodontal disease is. It's an infection. They are going to derail you. They will, because that's what patients do. Oh, I didn't floss. Remember Jim, my electric toothbrush. They are going to try to derail you. Don't let them do that. Tell them the truth. That's what they come to you for. They come to you because they trust you. Also, number 2, science has evolved. Remember, always be a lifetime long learner. And Tasha and I appreciate you so much being here with us today, because I know bacteria, it's a lot. It's not overly exciting. I get it. Trying to make it as best we can, folks. But be a lifetime long learner. This is our career. This is our life. And so you can make a difference. And so in those patients, so just remember, we've come a long way. You don't have to guess. You don't have to guess how infected this person is. We've got diagnostics. We know exactly, and we can treat that patient now. And do be concerned when a patient has systemic conditions. Like I said, we are healthcare providers. And remember, we are the only ones that are going to treat this infection. So as a dental hygienist like me, and if you are as well, they come to us for this infection. Nobody else treats it but a dental hygienist. And so, which I think we should be proud of. So anyways, thank you all so much for attending Bugs and Biofilm. Tasha and I, we've had a great time with you. I know bacteria, like I said, it's not overly exciting, but when you start doing more and start encouraging your patients, it's really rewarding. So please reach out to us. Listen, we would love to hear from y'all. Here's our email. It comes to both of us, and we'll respond. Or you can scan the QR code, takes you directly to our website. As you saw before, we both have our own individual companies, but we are kind of on the same path here with Boots and Bugs, and best friends for almost 20 years now. So we would love to stay in contact. And to make a change, we've got to stay together. We really do have to make a difference in dentistry. And so let's do this. Okay, y'all, have a good day.